sharing that address with you. Okay, so it's going to be recording starting now. Okay, just giving it another minute. Okay, Assalamu alaikum everyone. Again, the recording has started right now. Again, my name is Dr. Firdose Shabnum Ansari. I'm a diagnostic radiologist with fellowship in women's imaging, and we're going to be talking about breast cancer today on the platform of American Medical Women's Physicians Association. We will first begin with a prayer. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. Translation. By the passage of time, surely humanity is in grave loss, except those who have faith, do good, and urge each other to the truth and urge each other to perseverance. All right, so with that, we can start our presentation. Like I said, let me share my screen with you guys. You can see my slides. Okay. So we're here today on the platform of American Muslim Women Physicians Association. They are a nonprofit professional charitable organization. And the vision of AMWPA is to promote health, welfare, and education of women. The mission is to improve the condition of women's health, provide a platform for Muslim women in medicine, raise the awareness of issues regarding community welfare. Among all of the amazing things that AMWPA has done, including free community health fairs, donations, and youth mentorship programs, they've also done several important Zoom talks for the community, informing them about important topics such as, or any health topic. Our most recent was on mental health awareness and suicide prevention. These talks are very informative and impactful. And today we're going to be talking about another very important topic, which affects a large part of our population, which is breast cancer. Breast cancer is, is a diagnosis and treatment of breast cancer is a collaborative effort between multiple specialties, including radiology, oncology, surgery, radiation oncology, and pathology, which is why today we've gathered a distinguished panel of speakers who come from these specialties to discuss this topic and give us more insight. So this is me, I'm the moderator today. So like I said, I'm a radiologist and I specialize in mammography. And we have Dr. Sausan Abouharb. She is an oncologist, a breast cancer specialist coming from MD Anderson Cancer Center in Houston, Texas. Dr. Abouharb will be talking to us about the types of breast cancer, the stages of breast cancer, and oncological treatment options for breast cancer. We have my fellow radiologist, Dr. Sarah Khan, who is the founder and director of Eve's Breast Center in Southlake, Texas. She will talk to us about the importance of mammography and diagnosis of breast cancer. And we have Dr. Arsalla Islam. She is our surgeon specialist who will be talking to us about surgical treatment of breast cancer, and she's from Fort Worth, Texas. So I'm really grateful for all these wonderful speakers to join us today to talk to us about breast cancer. So what is breast cancer? It is a disease in which there is out of control abnormal growth of cells in the breast. There are different types of breast cancer. That depends on which cells in the breast turn into cancer. Breast cancer can start in one or both breasts and can spread outside of the breast. We can have different signs and symptoms or none at all in early stages. Different signs include lump, thickening of the breast, skin thickening, nipple discharge, nipple retraction. Dr. Sarah Khan is going to be speaking more about the signs and symptoms and what to look out for. Breast cancer is the most common cancer in women in the US, except for skin cancer. It accounts for approximately 30% of all new cancers in women each year. It mainly occurs in middle-aged and older women, median age is about 62 years, which means half of the women are much younger than 62 years. Overall, a woman in the US has a 1 in 8 chance of developing breast cancer in her lifetime, which is about 13%, and it is the second leading cause of cancer deaths in women. Extensive research and evidence tells us that regular screening can save lives. If you detect a cancer early, your doctors can take steps to prevent the disease from growing, from spreading, and causing death. There are a lot more options available for treatment when a cancer is detected early, and you can avoid difficult treatments if it is caught later. So what can we do to catch this disease early? How do we diagnose breast cancer? And what are the signs and symptoms of breast cancer? To talk about mammography and image-guided biopsies, I would like to invite Dr. Sara Khan, my fellow radiologist colleague, to speak about these issues. So please welcome Dr. Sara Khan. Would you please unmute yourself? You're muted right now. Dr. Khan, would you like us to share your slides, or do you want to share your own slides?
Hi, Shabnum. Thank you so much for your nice, sorry, I'm having a little difficulty with this machine here. I can't get my thing on it, the lecture.
Would you like us to show the presentation for you?
So should I just share the screen right now at this point?
If you have your, yes, slide up, yeah. Yes, please. Thank you.
So I press share screen. Okay, give me 1 second. And then what do I do here? So sorry. Let me take over from here. Okay. All right, here we go. Sorry about that. It's my first time, but thank you for your kind introduction. And I also want to thank Abouharb for giving me the opportunity to present on this platform. So we're going to begin with the first step towards a woman's breast health journey, which is where it begins here in radiology. There's many women out there that are fearful of getting their mammograms, maybe because somebody shared a bad experience that they may have had, or possibly due to the fact that they just don't think they need to have a mammogram. So hopefully by the end of this lecture, with the women watching this will probably understand the efficacy and the reason why we do this. And so let's start with the next slide. Typically people ask, what is a mammogram? And it's basically a high resolution x-ray that we use to find cancers or other abnormalities in the breast. Typically a radiologist who specializes in mammography will read these exams. And it's really important to know how to prepare for this examination. That's part of the process, so they have a good experience. Typically, a woman should come in with a 2-piece outfit because everything from above the waist will be removed. Please don't wear any deodorant, and basically to tie their hair back. The reason why I say no deodorant, because some of these deodorants can have some metals in it that can be seen on a mammogram and may be seen as something abnormal. If you're breastfeeding, we want them to be pump their breast out at least 1 to 2 hours prior to their exam. When you're in that room with the technologist, just make sure that you take time for yourself. Make sure you feel comfortable with her. Give her all the information that you need. If you feel that you have to exchange some information, these are the kind of things that we need to know. If there's been any changes in your breast, if you've ever had any prior breast biopsy, if you're taking any hormones like estrogen, progesterone, testosterone, or if you have any family history of breast cancer, that's really important as well. Let us know if you have any focal pain that stays there, is constantly there. Try not to hold it back. Let us know, because all this information that she gathers for us gives us a better idea of finding the area and honing down. Any trauma, or if you're pregnant, or if you're breastfeeding, all these things are important. Once in a while, we do have to do a mammogram on a patient who's breastfeeding or who is pregnant, but we do need to know that prior to. We don't typically encourage it, but if we need to, we will. Risk factors is also very important. Prior to your mammogram, we do ask these questions. If you're on estrogen, if you're on any progesterone, if you had your periods at a very early age, if you hit menopause very late, if you've never had a baby, if you've never breastfed, anybody in your family, like your mother or your sister that have breast cancer. Obesity is another real big problem as well, including physical inactivity. especially when you're postmenopausal. If you've had a history of ovarian or any endometrial cancers, we needed to know all this information. Alcohol consumption is also another risk factor. So when we get towards the ends of the slide, I'm going to talk a little bit about incidence of breast cancer and how these factors are very important. The obesity, any alcohol consumption, and first-degree relatives. So basically the mammogram, we'll start with this. When you get in the room, the technician will perform these 2 views of each breast, 4 views total. And then as you can see in this image, this is a screening mammogram. There's this radiologist pointing out an abnormality. So typically when they do that, they call you back for what we call a diagnostic exam. So it's important to know when you come in, you're first getting a screening mammogram because you have no symptoms. So first we'll discuss screening and diagnostic mammograms. A screening mammogram is usually a person who comes in with no symptoms, and she gets these 4 views done, and that's put into our hands to take a look and see and find disease or abnormality. These mammograms don't require a doctor's order, so you shouldn't miss your mammogram. They're covered 100% by your insurance, so they're typically free, so don't miss out for most insurances. They should be performed annually, every year. Some women don't realize that they should start at least at the age of 40, but there are exceptions. You can start at 35, but then you would do it at least every 2 years. These are the women with a higher risk, the risk factors that we just discussed. If a mother, for example, had a cancer at the age of 35, typically the rule of thumb is to subtract at least 10 years from the date your mother had breast cancer, and then you start after that. So in this case, a 35-year-old minus 10, you start at 25. Now, let's say we found an abnormality. You would be called in through your doctor to come back to do something else, which is a diagnostic. These are called targeted views of those areas. These mammograms require a doctor's order. You have to have symptoms if he calls you back, or you don't have to have any symptoms, but we find something on your screening mammogram. So we call you back to get these images done. And this is an example, the first image here, which is your screening mammogram where we find a finding. Then we call you back for this. This is a targeted view. So sometimes women get a little confused. They think they're coming back for the same exam only because we're using the same machine, but that doesn't necessarily mean we're doing the same exam, we're targeting it. And symptoms like this include things like a lump in your breast, a nipple discharge, any textural changes, you feel thickening of your breast, any skin dimpling, or any nipple discharge or changes, or any color changes of your breast. I found this really nice picture here that kind of explains if you have like a little thickened area, we'll go through some of these. If you have a little dimple in your skin and your breast, and around the nipple, some crusting, or an area that just looks red and hot constantly. Any fluid coming out of there, reddish fluid or even clear fluid, any ulcers on your breast, on the skin, or a bump, or even some vessels that you can see on the side. Sometimes the nipple gets pulled in, or you get a big, large mass that starts to show up and it really changes and distorts the look of your breast, or a little orange peel look on the surface, or you might even feel something hard like a rock. These are really important symptoms that are key to us to know and not to hide, but to let us know because you noticed it first. A new thing that, this is something that's been around for some time. We want to know about breast density. We always encourage our doctors to make sure that we notify your doctors or you. At our facility, we like to call the patient personally and let her know that she's got a high density, which means she's got more glandular tissue in her breast. The more glandular tissue, the more white breast becomes. So as you can see, this is a woman with a fatty breast. She has very little glandular tissue. But as you see the other pictures, these women have more and more glandular tissue. Now, lesions in the breast all look white pretty much, including calcifications. So cancer, cysts, or calcifications, a scar, some blood, all can look white. And so they hide much more efficiently on these type of breasts that are very dense. So the more dense the breast, the more whiter, we have to call you back to do a little bit more. So here's an example of a woman who has a little knot in her breast or a little mass, let's say. Here's a fatty breast. We can see it. Next year, she comes back to the center. We see this, easy to find. This one, another easy breast, you can find it. But as she gets very dense, these become harder and harder to find. So what do we do for these women? What's the next best step? We usually prefer to call you back for another imaging modality. In this case, typically, I like to call them back for what we call an ultrasound. Henda's law is another we'll discuss on the next slide, but the law requires us to tell you to do a little bit more. So we would probably push for an ultrasound or an MRI. Ultrasound, I think, is a little safer and quicker. Pretty much The person doing this exam should be a well-trained technologist or a doctor in the room that can actually image the breast while you're in the room real time and find the lesion. So the detection rate goes up substantially when we do a mammogram and we do an ultrasound on these women. What we're looking for is an abnormality. It can go up to 85 to 90% in the right hands. So next slide, we're going to show you the Henda's Law. Like I said, it started in 2012 here in Texas. So it's a really huge thing that we need to notify you by any means, whatever. Either we mail you, call you, or your doctor tells you. So the first option you have is what we call a screening ultrasound or screening breast MRI. The pros and cons, usually the patients don't know what's best. So we try to give you the best choice. This one's most inexpensive. There's no radiation. It's a quick and fast study. When we call you back, we don't require anything like a pre-authorization. So we can get you through the system relatively quick. There's no intravenous contrast or any contrast that we have to put or a chemical in your body. And it's a quite comfortable examination. We can also do a breast MRI, but again, that's a little more on the expensive side. Again, no radiation, which is good, but it's a longer exam. It's not very comfortable, but can be done. And it does require pre-authorization, which can delay your exam. So another thing is the contrast itself can also cause kidney damage, but we have to take all these things into consideration. So from that standpoint, I think the best would be to start with an ultrasound, if at all possible. Now, in an ultrasound, what we're looking for are these masses that you see here. And these are 3 separate examples. This woman has a very, very dark mass in the breast. This one turned out to be a cyst, and this is how they typically present. You also have solid lesions. Now, that's where it gets a little difficult. We have to make our decision what's next. I'm going to start with the one at the bottom. It's a very bright or hyperechoic lesion is what we call it. And these lesions are well demarcated. Usually are small little fatty areas in the breast. We usually leave these ones alone, but this is the one where we have the hardest time in. These can be tricky. Sometimes they're perfectly well-rounded, marginated, but they can still turn out to be a cancer. So, and this one's got little irregular borders. So this one would be more likely to be a cancer or something that's a little bit more worrisome. Either way, a solid lesion means all bets are off. We don't know what it could be, so we have to make our best decision, and that's when we come in and we kind of talk with the patient and let them know that we probably need to do something more, such as a biopsy. So here's a woman that came in, an example of a woman with a very, very dense breast. This little thing is a marker. But she presented with a mass, a palpable lump that she feels. But when we look at the ultrasound, the mammogram here, we can't seem to find anything. There's all this breast density. So we call her back, do her targeted views, and then still we can't find anything. So we put her on the ultrasound machine and boom, there you go. Here's a lesion with irregular borders. It doesn't look pretty. So we say, let's put a little biopsy gun in there and see what's going on. And this lady was biopsied and it turned out to be a cancer. So don't hesitate to let your doctor know if you feel something in your lump and you know it's there, just let them know. Give us an opportunity because that tells us to do something a little bit more. So here's how a breast exam would be performed. We put a little probe on top of you. This is an ultrasound probe. Ultrasound probe, and we place it over the area of concern. We place a needle that goes right through. Of course, we will numb you up. You're awake through the entire examination, trying to make you as comfortable as you can. You're laying flat on your back, and we put this needle through, as you can see here, the needle, and then we shoot the needle through the lesion, and we pull back the tissue. And this is what the specimens can look like. They're little long white pieces of specimen. We send it to the pathologist, which is another physician that will examine the images and then give us the response back in a few days to let us know what it is. And in this case, again, this was another cancer. So I'm going to kind of fast forward now. I mean, this is kind of like the information we want to let you know. So when you come in, being well prepared, knowing what you have to do, come in with a 2-piece outfit. Make sure you let the technologist know what's going on, what you feel, if there's any abnormality. These are all the things that make a person more comfortable in the setting. If you come, for example, if you wear 1-piece outfit and you're there, you're told you have to remove everything, it's uncomfortable. So all these things, knowing this now before you walk in that door makes you well prepared, and knowing that your technologist in the room is someone that you really should talk to at the time of examination, so that she can relay that information to us as the physician in the back room looking at your images. We don't have the luxury of seeing you on the day of your screening. But on the day of your diagnostic, we do like to come in and take a look and see these things and talk to you in person. So that went through all the steps pretty much, but now we're going to talk to you about incidence of breast cancer worldwide. As you notice that there's a higher predilection of breast cancer, a high incidence in these people who are in the more affluent society. Those affluent countries are much more inclined to get cancer. We don't really have an answer as to what causes cancer, but one of the big things is the meat and sweet diet. So in these countries, there's more access to that. And as you get down to these countries down below, they're more of the Mediterranean diet that we like, that we eat. And these people have a lesser incidence of cancer. So we think there's a little bit to do with that, but there's several other factors that we take into consideration. And remember I told you about, here's another way to look at it worldwide. You'll see the areas that are lighter shade and lighter. You'll see that it's, these are the patients that have a less likelihood of having cancer because of less alcohol. They're usually mobile, moving around and whatnot. So these patients have lesser incidence, and you'll see the higher incidence are the ones with the darker colors. Lastly, I'm going to say that you pull the same patients from those countries that are from the Mediterranean diet, put them here, and this is the one you want to look at, the Asians and Pacific Islanders. You'll notice in this country, United States, the gap gets closer because as you can see, when they come here, we start eating that meat and sweet diet. We have more access to these kinds of foods and these these type of factors around us. But anyway, that's probably the main thing. It accounts for about 1/4 of cancers globally around the world. And if that doesn't, that's a huge number. And in this country alone, 700,000 deaths a year, which is high. So just know that mammography does save lives. Please don't delay. And don't be uncomfortable, don't be fearful. If anything, that's what you got out of this lecture. We hope that it pushes you to make sure you get them every year and be consistent. And thank you, Dr. Shabnum. I'm complete and finished the lecture.
Thank you so much, Dr. Sarhan. That was very informative, very well done, and you covered everything very well. You can stop sharing your screen at this point, and but yes, that was very informative, and I'm sure people have questions. By the way, I forgot to tell you guys that if anyone has any questions, I highly encourage you guys to please put your type your questions in the chat box. We will have time at the end of our presentation to answer your questions, and your participation is going to make this presentation more valuable. So please type your questions in the chat room, and we'll get to as many as we can at the end of the presentation. So with that, I would like to invite Dr. Sausan Abouharb next to please come on and tell us what happens once patients get their biopsies and somebody has cancers, and what is it that you do to help people. So please, let's welcome Dr. Abouharb.
All right. Assalamu alaikum. Thank you very much for inviting me and having me over and being able to share this information. Are you guys able to see my slides? Just want to confirm that. Yes. Okay, great. So Jazakallah khair. I think Dr. Ansari and Dr. Khan did a wonderful job, laying out the foundation and the ground where we start. As dealing with breast cancer, this is a multidisciplinary team approach. So we talked already about the importance, the signs and symptoms, some of the risk factors when the screening starts. And I'm really going to focus on the two highlighted parts, which are the stages and the different types of breast cancer, and some of the treatments that we mainly use in medical oncology. So I'm going, focusing more so from a breast medical oncology standpoint. I know my colleague, Dr. Islam, will be talking more about the surgical approaches. So as you guys heard, the diagnosis, we either diagnose this based on routine mammograms. Patient comes in, they're asymptomatic, no issues. And we find this on a screening mammogram, which is usually the best case scenario because that means we've got it in the earliest stages possible. Sometimes it happens in a little bit younger females where they haven't yet started their routine mammograms. It's more noticed on a self breast exam. They feel a lump, this gets evaluated and checked out, and now we know what we're dealing with, which lead us to detailed breast imaging as well as biopsies. And unfortunately, if it doesn't get caught earlier on, sometimes we run into issues where patients present with not necessarily symptoms related to the breast, but unfortunately with more symptoms related to other organs, such as coughing, shortness of breath, severe back pain that's not usually controlled, and this does make us concerned for evidence of distant metastatic disease. Now, focusing more on the different types and stages of breast cancer, as my colleagues have mentioned, when we look at the breast, we have really fatty tissues, we have ducts in the breast itself. And the way that I like to think about it, over here we have normal breast tissue, and on the far away end, we have the invasive breast cancer. It doesn't really, sometimes it can happen very quickly, but it doesn't really happen overnight. We start off with the normal cells or normal breast tissue. Sometimes those cells divide very quickly, very rapidly, and when they do that, they do it in a correct manner. So we end up having something we call atypia, which means those cells are not normal cells, but they're not ugly enough to call them invasive cancer cells. So again, we have the normal cells, we have a little bit of atypia where it's a little bit off, but then if they continue to develop or duplicate very rapidly, and that's what cancer is, cells that divide very, very quickly. So they don't mature enough and they become the aggressive, ugly looking invasive breast cancer cells. Along the way, we have something we call non-invasive. And then, like I said, the more advanced is the invasive breast cancer. And that's where my third point says high-risk lesions. Those are more on the lines of atypia, which are earlier, much, much earlier stages, which are very close to more normal tissue than invasive breast cancer. I'm going to skip on the other few lines here and just share with you a bit of a graph that mainly looks at, I know this is a busy slide and it's rather medical, but I just want you all to know the most common types of breast cancers is something we call invasive ductal cancer, which happens on the ducts of the breast. And I'll show a picture here in a second. And then we also have something we call invasive lobular cancer, which happens on the surrounding of those ducts. There are other types of breast cancers that we see. Those are a little more aggressive, some are a little lesser aggressive, and this is where the pathologist comes in. They help us with this diagnosis and share with us additional information. So this is the slide that I wanted to share. So in the breast itself, we have many ducts. Those ducts end up in the nipple where the milk comes out from. Now, surrounding those ducts, as you can see here, we have, those lobules. Breast cancer can happen on the ducts or it can happen on the lobules. And that's where the pathologist comes in and helps us from a pathological description. And like as I mentioned earlier, most of the breast cancer cells we see are based on the invasive ductal. And then the second common type is the lobular. When we look at it as a cartoon, so like I was mentioning, we have the ducts, we have the lobules. This duct, it's like a straw. If I cut it horizontally, what happens is you'll see like a little pipe or a little straw-like structure. Now, this duct, it's lined by cells. And because it lines this duct, it's called ductal cells. And this is what we normally see. What cancer is, it's cells that multiply, multiply, multiply. When they're still inside this duct, it's what we call stage 0 breast cancer, or we call it in situ, means it's still inside the duct itself. So DCIS stands for ductal carcinoma in situ, which means came from the ducts. Carcinoma, fancy word for saying cancer in situ, it's inside the duct. Now, this duct, it's got a membrane. It's strong, but it cannot hold on forever. So when those cancer cells continue to multiply, what happens is this duct breaks, and then you have the invasive breast cancer cells. We're still in the breast itself. Sometimes it stops at the breast area. Sometimes it can travel to the lymph nodes or sometimes to distant parts of the body. But again, whenever it breaks this membrane in the breast, that's what causes the invasive breast cancer. For us as oncologists, or as medical oncologists, I should say, I know this is a cartoon. I'm not very tech savvy, so I drew this, and I want you to remember this picture a lot, or I want you to really focus on it, because this is what drives us as medical oncologists. And again, like I mentioned earlier, we work with the radiologist, we work with the breast surgeons, we work with the radiation oncologist. It's not one, it's a whole team really focusing on your best outcome. So on those cancer cells, with the help of the pathologist, we look at receptors, which are estrogen receptors, progesterone receptors, and HER2 receptors. And each breast cancer is different based on those receptors. Estrogen and progesterone, those can range from 0 to 100. So the higher the number it is, it's more driven by estrogen, more driven by hormones. HER2 is another protein, and it has a different system, 0, 1, 2, and 3. And again, you know, it's not one size fits all. I know you have the label of breast cancer, but each type of breast cancer is different based on those receptors, and therefore the treatments really depends on what this ER, PR, and HER2 are. So again, please remember this slide. I'm going to reference it again in the future. When we look at breast cancer, it's really important for us as physicians when we communicate together, and also when we're dealing with patients, to figure out what the stage of the breast cancer is. So this is an important question. If somebody was diagnosed with cancer, hey, to ask what stage am I dealing with? And I know this is a busy slide, but I just want to give you an idea. So we look at T, which is the tumor size. We look at N, which refers to lymph nodes, and we plug in those numbers, and this gets updated quite frequently. So there's probably a newer version than this. We look at the size, we look at the lymph nodes, and that gives us what stage of breast cancer that we're dealing with. We have different stages, 0, 1, 2, and 3, which depends if it's in the breast or breast and lymph nodes. And 4 is what we call stage 4 if it were to travel to distant or further parts of the body, meaning lung, liver, bone, etc. And the goals of our treatment, whenever we're dealing with an earlier stage breast cancer, 0, 1, 2, and 3, is really curing this patient and curing and completely getting rid of this breast cancer. But if we are dealing with stage 4, if it has traveled to much further distant parts of the body, lung, liver, bone, then we cannot cure it. We try to control it as long as we possibly can. So again, whenever we're able to catch it earlier on, so earlier stage, again, screen detected by breast imaging, by mammogram, it gives us the best outcome, it gives us the best survival, and that's why we definitely encourage the mammograms and the breast imaging. I know this is a busy slide, but again, if you can see here, like I said earlier, it really hinges what's the estrogen, what's the progesterone, what's the HER2, is it negative, is it positive? We work together with the surgeons here to see who goes first. Is it surgery? Is it medical oncology? Do we do chemotherapy? Do we do targeted therapies? Do we do endocrine therapy based on those 3 receptors? So again, when we're looking at the treatment of breast cancer, we're looking at the role of surgery, which is the curative part. We look at the role of radiation that kind of goes hand in hand with surgery for local treatments. In patients who have that little cartoon slide, who have strong estrogen, progesterone positive breast cancers, we look at pills, which we call them endocrine therapy, to help us block off the estrogen. We look at chemotherapy sometimes, which is the form of drugs that we give intravenously or in the veins, and there are many of them. And we have something we call HER2 targeted therapies or HER2 targeted treatments for those who have, again, on that cartoon, that HER2 receptor positivity. And we have a new class of drugs, it's called immune therapy. So when we talk about endocrine therapy, I've listed out a couple drugs that we have available. It really depends if one is pre or postmenopausal. But again, the goal of these drugs is really blocking off estrogen, blocking off hormones for patients who have hormone positive breast cancer. If you don't have estrogen, you don't have progesterone in your breast cancer, then you don't need those pills. But if you do, then we will use them and we would recommend them. How about chemotherapy? Some of it is oral, some of it is given in the veins. And again, I listed some names of drugs. And this is quite detailed. There really is a communication with your oncologist and your oncology team. Because again, think about it, if you have a urinary tract infection or a lung infection, you may give one antibiotic, but if you have a different type of infection, you'll get another antibiotic. Same for chemotherapy, depends on what type of breast cancer that we're dealing or what type of cancer that we're dealing from that standpoint. So that's why you might hear, you might hear somebody had breast cancer, but they're not getting the same exact treatment that you may be getting. And then for patients whose breast cancers are driven by HER2, this other protein that we talked about, we have specific drugs that target it. And again, we have long lists. We have lots of medications that are possible to use. And last but not least, we have something new on the horizon. This is very exciting. You may have heard something on the news or on the TV in regards to something we call immune therapy, which are certain drugs that are given in certain types of breast cancer. Again, those really kind of upregulate your immune system, trying to fight off the breast cancer. And again, those drugs, some of them are used in the curative intent setting. Sometimes we're dealing with metastatic disease. And our goal is to help prevent that, catch it before we are dealing with metastatic disease, because then we can't cure it. We palliate symptoms. There are certain circumstances if it were to travel to bones or other parts of the body, and each treatment depends on the location of that disease. And last but not least, we have something we call genetic breast cancer. We usually see this in patients who may be younger, in females who may have a strong family history, mom, aunt, uncle who may have had breast cancer, pancreatic cancer. So those patients might follow a little bit of a more intensive screening guidelines, and they may undergo risk reduction strategies. And again, it's really specific based on certain mutations such as BRCA, PALB2, CHEK2. And again, we usually find it in younger females, or if somebody has a male history, that is important to have that checked out and evaluated. And that is it from a breast medical oncology standpoint, and I will leave it on to my colleagues. Thank you very much.
Thank you so much, Dr. Sausan Abouharb. That was a lot of great information, put very concisely and very easy to understand. Really appreciate you doing this for us. And I'm sure if people have questions, we can get to that at the end of this presentation. I'd like to now invite Dr. Arsalla Islam, our surgeon specialist, and who's going to talk about for breast cancer surgical treatment options. So welcome, Dr. Islam.
Hey. Hi, everyone. So let's put on the first slide. So awesome. So hello, everyone. So we're going to go to the first slide. This is just the introduction. So what is the aim of the surgery? The first aim of the surgery is to completely excise the tumor, because we want to make sure that we can cure. We go in with a curative intention most of the times. We are going to talk about, okay, if the cancer has spread to other areas, what do we do? But we're going to, for some part of my talk, going to focus on the complete removal of the tumor from the breast. Also, we want to achieve that with improved cosmetic outcomes. We want to make sure that the patient is satisfied, and we want to make sure that it's going to positively affect the patient's quality of life. We don't want to have an ugly scar, or we really want to discuss it beforehand with the patient. Next slide, please. So it is a heterogeneous disease. It's not just one size fit all. It is something that, as my other colleagues alluded to, some of the cancers are easily curable with surgery. It's one surgery. They don't even sometimes need anything other than surveillance, depending on what stage it is. But we definitely want to sit down with the patient and discuss what stage it is, and we want to involve our radiologists, our oncologists. It's a multidisciplinary approach. And we also need our radiologists to find, of course, where the cancer is and where that spot is that we want to remove if we are removing partially the breast tissue. Next slide. So there is actually more than one kind of surgery. I'm going to show some pictures, but again, we coordinate with chemotherapy. Sometimes we do chemotherapy before we even go for surgery to decrease the size of the cancer. And sometimes we use reconstructive procedures, means we involve plastic surgeons in the discussion when we are trying to figure out what kind of surgery is best for our patient. Next slide. So this is just a picture of a breast tissue with lymph nodes on the side going to the axilla, going to the underarm. Usually we don't remove the small green lymph nodes below the clavicle, below that bone. We sometimes have to remove some of the lymph nodes in the axilla, because that's where the breast tissue drains. And there are certain special kinds of surgery that we do. That's called sentinel lymph node biopsy. So we do that to see if even though the tumor is in the breast tissue, but has microscopic spread gone into those lymph nodes or not. And that is really important. That actually give us the stage of the breast cancer, which is the T is the tumor size, and is it involved or not, N0 if it's not. Next slide. So mastectomy basically means removal of the breast tissue, skin, and the nipple. And we do it with or without the lymph node dissection. If it's not involving the axilla, we usually do not remove the lymph nodes there after the sentinel lymph node biopsy. Sentinel lymph node is just 1 or 2 or 3 lymph nodes that mainly drain that breast tissue or that area around that tumor. Partial mastectomy or lumpectomy is where we make a small incision and just remove a little bit of the breast tissue. If the breast is bigger in size, it has a cosmetically better result. But if the breast tissue, to start out, it's a smaller breast size, then this is not the best cosmetic option. And we discussed mastectomy and reconstruction at the same time. Oncoplastic techniques are basically skin sparing mastectomy, where if the tumor is not involving the skin, of course, it's away from the skin, that we can spare the skin and the nipple and the areola and remove all the breast tissue underneath if we have to, and then reconstruct at the same time using that nice skin and subcutaneous tissue flap to cover either it's a autologous tissue, which is coming from your own, that patient's own tissue, or there are some implants as well. So if the early stage is best cosmetic outcome, and that's best when women are involved in screening and they're doing, of course, there are several guidelines as we've discussed in detail, but screening is very, very important. You want to get to these tumors early on rather than late in the game. And also there are some high-risk patients who just, because of this family history or other kinds of risk, they want to undergo prophylactic mastectomy, and we do that as well. Of course, we have to discuss that. Okay, this is going to be a surgery and it has complications, and what are their expectations? So it's really a multidisciplinary approach. It is not like 20 years ago, it's not like, oh, the breast comes off, and no, it's a lot more detailed, luckily, and especially because we have improved survival of breast cancer patients. So those patients are going to be alive, and they do want a good quality of life. So it's very, very important. It's just not one sitting, it's several sitting with several doctors and discussing what's the best for the patient. And the patient input is the most important thing, of course, after the safety of the surgery. Next slide, please. And this basically just tells us about the early breast cancer, if it's 2 centimeter or not. Again, there are several algorithms that are in place. We follow hormone treatment, chemotherapy, radiation, along with the surgical treatment to get the best results for the patient. Next slide. So this is just the breast conserving surgery, which is lumpectomy. You can see that on the left side, there is a tumor, and we remove that with the rim of normal tissue, and we send it for the pathology. And we want to make sure that the margins are clear. We don't leave the operating room until we know that we have a negative margin. If the margins are negative, that's when we say, okay, we're done. And then we close the tissue and close the skin. Postoperatively, sometimes there's an indentation. And again, sometimes it's best to do this for a larger breast rather than a smaller breast. And smaller breast, we do discuss subcutaneous mastectomy, where we leave the skin and then remove the tumor with the re-implantation at the same time, or implant at the same time. Next slide, please. This is a picture of the modified radical mastectomy. Basically, what it means is that it removes breast tissue and the skin and the nipple and the areola, plus the lymph nodes that are draining that breast tissue. It does not remove the lymph nodes that are underneath the clavicle or a collarbone. It just removes the tissue that is draining the breast. And this is still done sometimes. And some patients, they don't want an implant, they don't want reconstruction, and they are happy with this because they want just one surgery. And even with one surgery, you can do one surgery where you're creating a flap and involving plastic surgeons. Your thing is done, you're done with removal of the breast cancer, and then the plastic surgeon time starts and they actually reimplant. But in this case, of course, the patient has decided to go with mastectomy. Next slide, please. So this is where you can see that on the left side, there is rectus abdominis muscle, and we actually, the plastic surgeons do this part. They are going to basically take that area of the abdomen, so skin, subcutaneous tissue, muscle, along with its blood supply, and basically go underneath that skin and create a very cosmetically desiring result with that tissue transposed into a flap. And then, of course, they follow up with the plastic surgeon to make sure that the blood supply is good. Occasionally, even though they do a good job, the margins can become ischemic and darkened. So it really needs a very good follow-up with your plastic surgeon after this. Next slide. So, so far we just discussed that surgery for like breast cancer, but there are several patients that may consider risk-reducing surgery before even the cancer appears. And the list is long. And, you know, of course, you discuss it with your oncologist or your OBGYN who's involved in your care to see where you want to be referred to. But basically, patients who have inherited breast cancer syndromes like BRCA1, BRCA2, P50, TP53, CHEK2, they sometimes go for both-sided mastectomy and reconstruction because they have high lifetime risk of breast cancer, and they don't want to go through the anxiety of going through very scrupulous screening every year. So they just go for breast bilateral mastectomy. Or there are some patients who have cancer on one side, but not on the other. And because there's more risk on the other side, they just want to go contralateral, the other side, prophylactic mastectomy at the same time as that side, so that they have cosmetically desirable results, so that it's symmetrical. And that is also an option. Again, the options are so vast and so variable now that you have to sit down and discuss with patients and let them know that these are their options. So some patients also go for bilateral salpingo-oophorectomy, where they're removing ovaries, so that if they're especially there's risk factor for ovarian cancer also, and then also ovaries form female hormones that can cause driving force to develop that breast cancer if they have inherited breast cancer syndrome. So you have to weigh and balance the benefit of reduced anxiety relating to developing breast cancer, but then also having increased risk for like anesthesia complication, risk of surgery, risk for reconstructive surgery, and then of course that also we discussed the adverse feelings related to their own body image. So it's a very, very important part of our discussion with the patient. And that's really it for my part. Thank you.
Thank you so much, Dr. Islam. That was great information, and you put it very concisely. And I hope that our audience has learned from this. And that we covered, I think, everything with just the basics of the radiology, of surgery, of oncology related to breast cancer. And so we're open for questions now. And I'm going to see if we have any questions. I think there's somebody had asked a question about what is the incidence of breast cancer in South Asian women? Let's see, who would like to take this question? I think Dr. Sarkhan, you had a slide talking about incidence of breast cancer.
Well,
so
it depends. Yeah, well, it really depends if you're in this country or if you're in the Asian country itself of origin. It basically, I can't give an exact answer, to be honest, but I can tell you that the women that comes from the Asian countries to migrate to the United States, the incidence increases only because of the risk factors that we have here. I mean, and also because of the food, the availability of like, let's just say McDonald's and all these big companies, and they give you great fast food. I'm not trying to say bad about McDonald's, but these fast food restaurants are eating heavy carbohydrates, all these kind of things. We think that might be the meat and sweet diet that's contributing to our incidence of cancer in this country. Obviously, there's other things that we think could be a problem, but really watching your weight, making sure that in this country, we have very much obese patients. You go back to the third world countries and you'll see these patients that are, these people, they don't have that problem. So again, it has to do with your accessibility to fast foods and, being not exercising, not taking care of your health. Those are the issues that I think contribute to increased incidence in this country. But the exact number, I really can't say. I'm sorry about that.
Okay. I think the incidence is actually, that's right, we don't have an exact number, but incidence in Asian women is actually lower than incidence of breast cancer in white women. It is, but the mortality in Asian women is higher than when compared to the incidence. So I think that's also because of, a lot of Asian women don't feel comfortable getting their screening mammograms. And I hope that today after this presentation, we realize how important it is to get that screening mammogram and to catch those cancers early when they're small enough to be treated, to not let it, needing lumpectomy or maybe just lumpectomy and not anything else. Or, there are, like Dr. Abouharb also discussed, we do have options of treatment, but the earlier you catch these diseases, the simpler the treatments are and the chances of a complete cure are higher. So even though the incidence in South Asian women is lower because of the higher morbidity and mortality, I highly recommend South Asian women to be diligent about screening mammograms every day. Every year to get your screening mammograms starting at the age of 40. And do definitely discuss with your doctors to see what has been discussed. There are some people their risk factors are higher than others, so it's very important to have that one-on-one conversation with your physician to figure out what is your risk and if there are any special considerations that you need to take. There is another question here. It says also, is one breast more sensitive than the other for prone to cancer? Who would like to take that question? Dr. Abouharb, would you like to answer that question?
So, sometimes I have patients who share with me like, hey, this breast is more sensitive, or I have more itching in one versus the other, or somebody has developed breast cancer in one, it started off with, pain, now I'm having pain or sensitivity in the other. Is it really a sign? It's really hard to say. I don't know that it can, necessarily correlate, but I would just say, definitely check it out. Make sure you're up to date on your breast imaging, make sure you're up to date on your screening. If you're feeling a lump or something hard, then that would be more of a concern, but I would just make sure you're up to date on your screening and all of that.
I agree. And you can get breast cancer in either breast. It doesn't have anything to do with, which side. And definitely, like Dr. Abouharb said, please keep an eye, check, with physical exam, you should know what your breasts look like, and you should know when there is a change. With that in mind, there's another question here. Someone wants to know, women who have dense breasts, do they have more chances of getting cancer? How about Dr. Islam? Would you like to answer that question, or Dr. Sarah Khan, either one of you?
Do they have higher risk of having cancer?
Yes. The question is, women who have dense breasts, do they have more chances of getting cancer?
No,
it's like, I guess it can, yeah, go ahead.
Yeah, no, not higher risk to my knowledge, but definitely it's going to be harder to detect breast cancer just because, but our radiologist friends just discussed that on mammogram. They have special techniques that they can utilize to detect it. But no, to my knowledge, women with denser breast don't have higher risk for breast cancer itself.
I'd like to add that mammography has its limitations. So like I said, whenever you have a dense breast, things can hide. When we show that scan with the little nodule, how it hid in that dense breast. And another patient that I showed that felt a lump, but we couldn't see anything. But she kept insisting she feels something. The ultrasound was very valuable in helping us find. So that's what helps us increase our detection rate to 85 to 90%. So definitely, if doesn't
How about
increase the risk.
patients, Dr. Khan? How about
Yeah.
MRI?
MRI is very good too. MRI is very sensitive though. It'll pick up a lot of things, and sometimes it picks up too much. And then for the breast surgeon, it makes it very, very difficult because, you know, they'll turn around and ask us, so what do you think? What do you think? And, you know, without doing a biopsy, we don't know, but it can pick up so many things that are normal too. So I think ultrasound has been much more efficacious in helping me make my decision, my choice. I leave MRI for patients who I have difficulty finding something both on mammogram and ultrasound. I like to push them that way. Or if I found cancer, then I want to see if there's any residual disease on the other, you know, not residual, but more disease in the same breast or on the opposite side. So before she goes to you for a surgeon, you know, you need to know these things. So maybe we might want to do a double mastectomy as opposed to just a lumpectomy or something. So yeah, that's when I really push the breast MRI after we find it, or if I have a really difficult case where I can't find it with ultrasound.
Mm-hmm. Definitely agree with those answers, and I think that answers the same. Same person had asked a question about how can ultrasound help. So I think that answers that question. There's another question about what food should people eat after breast cancer? Is vitamin D good to prevent the spread of this cancer? Yes, that's the question.
I can take that on. So kind
Okay.
of goes with what I do also. So I'm also a bariatric surgeon, and I will say that initially in my training, we were like, okay, we're going to do bariatric surgery when patient is cured of cancer, when they are like outside of that window, or 5 years or 10 years out, even if the patient is like under surveillance. I, during my training, and my mentors would not take on that case. Things have changed so much. Now that if the patient has had their treatment, it is so important to lose weight. It is important to lose weight because if there is a spread of cancer, and it's not just breast cancer, it goes to meningeal cancer, lung cancer, prostate cancer, kidney cancer, colon cancer. I mean, you name it, skin cancers. So obesity is a huge problem with cancer. So going for a healthy diet, which we should all do anyways, whether irrespective of if we are high risk for breast cancer or not, is important for all of us. So eating very little at a time, focusing on protein and nutrients rather than carbs and empty calories. Like we all know what the empty calories are. But eating healthy and small portions is so important, and daily exercise is so important to keep your weight in a good range, and not even like a BMI of 30, which in the United States, like 65% population has a BMI of more than 30, which is, like overweight to obesity range. So that is important. Vitamin D's role in prevention of cancer, I don't know. So I'll ask Dr. Sausan to take that question.
So I think there's a lot of, conflicting data evidence, but what I tell my patients, I've noticed, a lot of people are just vitamin D deficient. So some of the drugs that we give can increase the risk of osteopenia and osteoporosis or weakening of the bones. So I actually do recommend, generally speaking, unless there's a contraindication, but generally speaking, I do recommend for our patients to be on vitamin D, just daily, small doses, daily supplemental dosing, whether they're getting it from their, dairy intake or supplemental through pills. I think either way is fine at that end.
Okay, that's great. While you're on, Dr. Abouharb, there's another question about, I think you could take this one. It says, if someone loses weight unexpectedly without any stomach issues, can it be a sign of cancer?
So it depends on like how much weight loss and what period of time. If somebody loses, unintentional, let's say 20 pounds in a month or two, this is unintentional, decreased appetite, I would definitely try to get that checked out. Yeah. 10 pounds in a year, it's hard to say. That's kind of hard to say. Roughly that's a pound per month. But if it's something unintentional, unexpected, I think it'd be better to check it out. It may not be cancer related per se. It could be some other hormonal issue. So something less severe, but it is something that would be worthwhile developing.
Okay, definitely. Another question here, maybe Dr. Sarah Khan can take this. Says, I heard some people complaining of repeating the images and insurance does not pay.
So it depends.
They may be talking about if I don't think they're talking about diagnostic. I think they're talking about coming in for a screening with maybe inadequate or technically limited, I'm assuming, or in either case, what is your advice?
There's two kind of repeats. One might be you're coming back in because the images that we have on hand are not adequate. There might be something missing, maybe not a good image. I mean, we have to tell you if it's not good. The majority of the cases are now done digitally, so I don't really find too many patients that come to our center and say, oh, we want to come to you. Can you look at this and, you know, take over from here? I take over from what I see there. That's one kind of repeat. If it's something that's it's just not satisfactory, I'll ask them to have it redone, but it's far and few between. However, I think if you're the other type of maybe quote unquote repeat is where we're actually doing a targeted view. And that's what I mentioned in my exam. When we call you back, for example, you come for a screen and we see a finding, we're not doing the same image. We're using the same machine, but we're doing targeted views. We're splaying the tissue out more. We're trying to look in that dense breast. Is there something really there or not? If there's tiny stones, we need to determine what kind of stones are they? What do they look like? So we're doing more magnified views. So a lot of times patients misinterpret when we're calling you back in and they see the same machine. They're like, well, wait a minute, why is she doing the same thing again? But we're really not. They're totally different images. And so there's, like I said, two type of repeats. If it's really, truly bad, I usually show my patients and I say, look, this is what I have. Or they didn't send me a portion of your image. I mean, things happen. So, you know, we can't give you an answer unless we hold the whole examination in our hand, or we have to call you back for really to look better at something.
Yes, and those are diagnostic exams should be covered by insurance. The same person who asked about weight loss wants to know, you said that, you know, if there's weight loss of more than 10 pounds in a year, you should get yourself checked out. Their question is, check out what part exactly, and also what tests rule out cancer in the body for unexpected weight loss? Like, what exactly should their next steps be?
So this is a tough question. Usually we get patients after they've been diagnosed, but generally speaking, I say, please make sure you follow up with your primary care physician. They would start off by getting a good physical, good history. They may request some routine blood work, checking your white count, your hemoglobin, your liver, your kidney numbers. If you have certain symptoms, they may consider doing CT scans or MRIs. They may say you have to do a colonoscopy. So again, they would have to factor in your age group. Are you up to date on your pap smears? Are you up to date on your mammograms for females? You know, if there's, you know, urinary symptoms, if a male, would they check prostate? So it really depends on, you know, symptoms, certain blood work, something that they're trying to look for from that standpoint.
Yeah, that's right. And if you have no symptoms at all, still your primary care physician will know what to do. If you have weight loss and there's you know, we know what to do, what to look for, what kind of tests to do to see, just like Dr. Abouharb said, like, depending on your age and, you know, you're a female or a male, we know what protocol to follow to check for what could be going wrong. So just first step is to speak with your primary care physician. And in addition to everything that Dr. Sausan said, they may want to do a pelvic ultrasound if you're a female, just to rule out some of the, you know, the cancers that are most common. So they will know what to do. So the first step would be to go speak with your primary care physician. And the other question are, yes, I think you answered this question. All blood tests are normal. Can we get endoscopy and colonoscopy done? Those are, and the woman is 44 years old.
So I guess I can take this on. So if 44 and all their blood tests is normal and they have an unexpected weight loss, is that the indication?
Yes,
for
yes,
endoscopy?
more than 10 pounds. And is that an indication for endoscopy and colonoscopy?
In itself, a 10-pound weight loss is not, unintentional weight loss is not a indication for colonoscopy, but this patient is reaching very close to the 45 age group anyways, which I think is the work for the American College of Surgery for colon screening. You know, with, of course, thyroid screening, diabetes. I mean, if you're not as active, maybe there's muscle wasting, you know, I mean, depends, just that the primary care physician has to go through all that. But a colonoscopy, you can make a very, I mean, colonoscopy is very easy to get nowadays, but it won't be screening at that time. It would be like, okay, we're suspecting that there's unexpected weight loss. and colon cancer is one of the common cancers in United States. So I think we can definitely do that. Also, we can do a guaiac. We can check our like on the lower side. Then yeah, colonoscopy is a good idea.
Okay. Another question is, any supplements you recommend to prevent cancer? Who wants to take that one?
Dr. Sausan should take that.
I wish we knew. That's the honest answer. We're only giving it out. I don't know that there's anything in particular that we, specific, like Dr. Aslam was saying, it's really trying to do that healthy diet, exercising. Those are the things that you can use to help reduce the risk of cancer. Generally speaking, and even in breast cancer, they've looked at patients who are obese or overweight and people who maintain healthy lifestyle, exercise, healthy diet, and those who had better control of their weight, better control of their diet, they had better outcomes compared to the ones who were overweight or obese. So there is some data in that. Not really, unfortunately, there's no magical pill that can, we would recommend to prevent cancer, but I think it's really just trying to, again, healthy eating. If you can grow your own garden, I would go for it.
Yeah, that's right. But guys, we're coming up to over an hour, but I think I don't see any more questions right now. But this was great. I mean, you guys, all of you speakers did a really great job. Thank you so much for doing this and taking this precious time out of your schedules to do this for us. Any closing comments you would like to add?
No, just
We can start.
I'd like to just say, take the fear factor out, and knowing what you need to do to prepare for the examination, feeling comfortable with the technician. I think some things that we have to take into consideration is when we get a mammogram, sometimes people don't understand the cultures, the differences in culture and so forth. Make yourself, comfortable. We get women who wear hijab, for example. We want to make them feel comfortable. We let them know there's no men in the room. There's nothing like that. Making a person feel warm and comfortable, that's key at a center. But knowing what you need to do, for example, they wear the whole jilbab and they don't know they should have worn just a two-piece outfit underneath. That already sets the tone. They feel upset, they're angered. And so, hopefully this lecture, you understand how to be prepared when you walk in. Don't worry, you don't have deodorant on. These are all the things that, when you go in and you feel comfortable with the technician and tell her everything that you do, talk to your doctor, let them know about your symptoms, because that honestly makes it easy for us to hone down and look harder in you. And at the end of the day, early detection is the best deal for everybody, for all of us doctors. We love that. We like to catch it early. It makes all these doctors' jobs easier for you and makes your outcome the best. So another thing in our culture, I noticed the question should be asked, like, how do our Asian women come often for their exams? They don't. They once in a while they'll come in and they're like, well, I had a normal exam. I don't need to come back. There's about a 30% risk. I mean, already, we see these all the time. They skip their mammograms for a year or 2 years. Had they come, we would have caught it when it was much smaller. So don't miss that 1 year. It's covered by your insurance. It's basically free. Don't omit it. Come in, find a way to get it done, because that early detection is key.
Yes.
And I think, whoever does her mammogram, I would just suggest maybe trying to encourage your friends, your family members around you. I think when somebody hears, directly, hey, I've had my mammogram, I encourage my friend to do this or that, I think all of us would feel a bit more comfortable, proceeding with it, since somebody who has experienced it, and it wasn't, it helped them. It helps them, and it helps yourself at the end of the day from that standpoint. And that's what we're here to, do together.
Thank you.
I want to add one more thing, if you don't mind. Another complaint that we see is, it was so painful, so difficult, so awful of an experience. One of the things I tell them that, take a Tylenol, take an Advil at least 1 hour before and 1 hour after the examination. And when you're in the room, let the tech know. Let her know, oh, it's painful. She needs to slow down. A lot of us don't think we can talk to them. We can say anything. You should. Because you cannot, the way I teach my technicians is you cannot make that breast flat like a pancake. You can't make it paper thin. It's a 3-dimensional object. So you take a look at the woman's face, watch it, and if she can't understand you, holding your hand out, saying stop, hold up, do it. Because the first experience, if it's the best experience, those women come in consistently every year. If it's your worst experience, chances are you might not want to come back again. So do speak up and, don't hold your feelings back. And that's it. Sorry about that.
No, thank you. Okay. So just on closing, I'm going to share one more slide with you guys, just with, if anybody wants just a website with resources, especially for mammography. And this is also going to show you the website where we're going to have this presentation on our YouTube channel. So let me share that with you. I think it did not come through, looks like. Okay, well, I'm really sorry about that, but you can go to Society of Breast Imaging website. They have multiple resources. On American College of Radiology website has multiple resources for you. And our, if maybe perhaps Diana, if you could just type our YouTube channel in the chat, that would be very helpful. So people have that. Okay, before that, one last question we can take, maybe diabetes and cancer, any correlation?
So there are some studies that looked, I don't know if exactly through diabetes, please forgive me, but it looked at insulin growth factor, which is studied in diabetes. And, a lot of times patients who have diabetes, they use the medication metformin to help lower their diabetes or have, better glucose control. There are some studies in breast cancer that looked at metformin and the use of that, but I don't know that there's a clear cut. I think it comes again from trying to manage the weight loss and the exercise and the activity. But I don't know if I could say that, hey, because you have diabetes, you have an increased risk of breast cancer. I don't know that we have a direct link from that standpoint. But there are some studies that are looking at metformin and what we call insulin growth factors, which play a role in both, basically.
Okay, all right, thank you. Yeah, somebody said that they cannot see my last slide. I apologize for that. I think it did not load for some reason. But the YouTube channel is youtube.com/AMWPA. You will be able to see this recording after Monday in 24 hours. It should be loaded for if you want to go over this again. Again, I thank everybody, the audience, to join us. Thank you for joining, and please share this information with your loved ones. It can definitely early detection saves lives. And thank you, Drs. Abouharb and Dr. Islam and Dr. Khan, for joining us again, and AMWPA for allowing us to use your platform to spread this important message. So thank you, everybody, and I hope you guys have a wonderful day. Enjoy the rest of your evening.
Thank you.
And the weekend. Assalamu alaikum.